Thank you for the kind invitation. Happy to be here after the red-eye flight from Seattle. I was at the mercy of air traffic control, and they let me through. So yesterday in Seattle, I was asked to give a 4-hour presentation on updates in breast cancer with one 10-minute break. Today I'm going to try to cover that same material in 25 minutes. So I'll set records on both coasts on that front. So stay alert here. I'd like to begin with a discussion of data updates from ESMO, Berlin, just a couple weeks ago, for early-stage hormone receptor-positive HER2-negative breast cancer. This is the monarchE adjuvant abemaciclib clinical trial. These are hormone receptor-positive, HER2-negative, lymph node-positive, high-risk early breast cancers. They were given if they have high risk, defined as greater than 4 or more axillary lymph nodes, or 1 to 3 nodes with some other risk factor like high grade or high T stage. And then there was a cohort 2, which is only about 9-10% of the patients with positive nodes and a high Ki-67 greater than 20%. And they were randomized to abemaciclib with endocrine therapy or endocrine therapy alone per standard of care. The abemaciclib was 150 BID for 2 years. And here is the primary endpoint of IDFS in the intent to treat population at the latest data cut just presented, as I mentioned, at ESMO. Abemaciclib and endocrine therapy reduced the risk of IDFS events by 26.6% compared to endocrine therapy alone. So note that the curves continued to diverge significantly after the 2-year period of abemaciclib administration. So that's very reassuring to see that this appears to be a long-term effect and not just a short-term effect while patients are on drug. There were no new safety signals in this data set. If you look at the upper right-hand box, you'll see the patients that are alive with metastatic disease, and 30% fewer patients on the abema arm are living with metastatic disease, and most IDFS events were distant metastatic events in this particular trial. So these are big clinical impacts for these patients. For the first time, overall survival was significant in an adjuvant CDK4/6 inhibitor trial. This is highly statistically significant. There are over 5,000 patients randomized in this study, so it's got big statistical power. And this is a first. So this is a historic event to see an OS benefit from an adjuvant CDK4/6 inhibitor. And this is with a median follow-up now of 6.3 years, and it reduced the risk of mortality by about 16% compared to endocrine therapy alone. So quite a remarkable achievement. If you look at the forest plot on the right-hand side of the slide, you can see there were consistent OS benefits across pre-specified subgroups. So great data consistency. All the point estimate hazard ratios were to the left of 1, and all the 95% confidence limits overlap the all-patient population shown for reference at the top of the chart. So it's very reassuring that the data are very robust and consistent across the board. Next, I'll talk about the second FDA-approved adjuvant CDK4/6 inhibitor. This is from the NATALEE trial with adjuvant ribociclib. This patient population is completely different from the trial population of lymph node positive high-risk patients I just shown you in monarchE. This patient population is much lower risk because lymph node negative patients were allowed in this study in addition to lymph node positive patients. However, the node negative patients still had to have some high risk factor, such as elevated Ki-67, high-risk Oncotype DX score, or some other high-risk genomic profile like mammaprint, et cetera, or high grade. And positive disease was also allowed in this trial, but there was a large fraction that had lymph node negative disease. They were randomized to ribociclib 400 milligrams a day, not 600 milligrams a day, which is the metastatic dose. I've seen in my clinic patients coming out on adjuvant ribociclib at 600 milligrams a day, and that's not the correct dose. It's only 400 milligrams in the adjuvant setting. It's given 3 weeks on, 1 week off for 3 years in this trial versus a non-steroidal aromatase inhibitor alone. The primary endpoint is invasive disease-free survival. And at ESMO, we saw the 5-year pre-specified analysis with 55.4 months of median follow-up. These are the results for the node negative on the left and node positive on the right subgroups. At this 5-year follow-up, NATALEE, ribociclib plus AI continue to reduce the risk of recurrence beyond the 3-year treatment window, supporting its use as adjuvant therapy in patients with hormone receptor-positive early breast cancer at high risk of recurrence, including those with high-risk node-negative disease. And once again, that is a first to have activity of an adjuvant CDK4/6 inhibitor in a lymph node negative population that had never been demonstrated prior to this study So again, a landmark result from another massive trial of more than 5,000 patients also. Next, I'll talk about a new class of drugs, two of which have gained recent FDA approval. These are the oral selective estrogen receptor degrading agents, oral SERDs. Now, you may recall that Suzanne Fuqua first discovered ESR1 mutations in San Antonio back in the early to mid-90s. She described one patient with metastatic disease who had an ESR1 mutation. Then she and others went on to sequence a lot of primary breast cancers for ESR1 mutations and found that the mutation frequency in newly diagnosed primary breast cancer is less than 1%. Consequently, that field was ignored for more than a decade because nobody wanted to tackle such a rare mutation. It wouldn't pay off in the long run to develop new drugs for such a rare target. So it was ignored completely for a very long period of time until finally someone had the presence of mind to sequence patients with metastatic disease. And first-line metastatic disease, the ESR1 mutation frequency increases to about 5%. Second line, a third of the patients have these mutations. And by the third line of endocrine therapy, you're talking 40% of the patient population has ESR1 mutations. So now, suddenly, this became an interesting target, and finally, drug development has ensued in spades. So these are patients who have progressed or relapsed after 1 to 2 lines of prior endocrine therapy for advanced disease, one of which had to be in combination with a CDK4/6 inhibitor. They were randomized to elacestrant, 400 milligrams a day, or investigator's choice of standard endocrine therapy. There were 2 primary endpoints, PFS in the all-patient population and PFS in the ESR1 mutant population. And the Kaplan-Meier plot on the upper right-hand corner is the primary endpoint in the ESR1 mutants that showed a statistically significant superiority of those patients randomized to elacestrant compared to fulvestrant in this trial. Note, however, the shape of the Kaplan-Meier curve. There's a sudden drop at the first restaging interval in both arms, both the control arm and the experimental arm have a precipitous drop of progressors at the first restaging interval. So if you use this in practice, it's really important to do the first restaging on schedule to weed out those that are resistant to this approach a priori. So that's the important take-home lesson for this new class of drugs, and I'll show you other curves with other agents that have a very similar appearance. Here's a clinical trial called EMBER-3 that led to FDA approval of imlunestrant, a second oral SERD that was recently approved just the end of September by the FDA. Look at the upper left Kaplan-Meier plot. Again, you see that steep drop-off. The first maybe 30% of patients or so do not respond to this type of endocrine manipulation, even with ESR1 mutants and appropriate oral SERD randomization. They still don't respond. But then the curves split after that, and significantly so. Hazard ratio of 0.62 in this case, with a p-value of 2 zeros after the decimal. So a highly significant result. If you look at the all-patient population in the lower left, you can see that the efficacy signal is diluted out by the wild-type receptor patients. So this works primarily in the ESR1 mutants rather than the wild-type ESR1 sequence. The interim overall survival analysis is shown in the lower right-hand Kaplan-Meier plot. This is not yet statistically significant because it's immature, but there's a favorable trend in favor of those randomized to the imlunestrant arm. This OS analysis is only 31% mature, so longer follow-up will be needed to make any declarations regarding OS in the future. Another aspect of this trial was an interesting arm that included imlunestrant plus abemaciclib, and that Kaplan-Meier analysis is shown on the upper right-hand side of the slide. This was a significant result, and the safety signals were just the composite of each component drug, and consequently, it looks like this will be feasible from a clinical point of view to be able to use this combination in the future. This combination data has not yet been submitted to the FDA, so there's no regulatory action yet on this data set, but it's hoped that there will be future approval of such combinations in the not-too-distant future. Next, I'll talk about another way to destroy the estrogen receptor, and that's with a PROTAC drug. This one's called vepdegestrant. It's a bifunctional molecule. One side of the molecule binds to the estrogen receptor. The other side of the molecule binds to E3 ubiquitin ligase and brings it in close proximity to the estrogen receptor protein, leading to polyubiquitination of the estrogen receptor protein, and that targets the protein for degradation in the proteasome. So a really interesting mechanism of action and a very effective drug class for the estrogen receptor and probably other oncologic targets in the future as well. But this is a first of the VERITAC-2 trial showing efficacy of this approach. The Kaplan-Meier plot for the ESR1 mutants is on the lower left. This is a significant result, favorable hazard ratio, statistically significant. And again, you see that steep drop-off at the first restaging interval, just like the oral SERDs. Now, oral SERDs also have a similar proteasome degradation mechanism due to misfolding of the estrogen protein after binding to oral SERDs. So I expect that we may see cross-resistance between PROTACs and oral SERDs, but no one has done a clinical trial to test that hypothesis yet, but those trials will be done, no doubt. The all-patient population on the lower right-hand side of the slide shows, again, dilution by the ESR1 wild-type sequence patients which dilute out the efficacy signal. Excuse me. This is a particularly well-tolerated agent. As you can see from the table in the upper right, there are very few grade 3 or 4 adverse events with this agent, so that's very reassuring that this should be clinically feasible. There's no regulatory action yet for this agent. It's not yet available, but it's hoped that based on the strength of this trial, there may be a regulatory approval in the future. Next, I'll talk about the ASCO plenary session this year, which boasted the SERENA-6 randomized phase 3 clinical trial. This is a phase 3 randomized double-blind placebo-controlled study of estrogen receptor positive, HER2 negative advanced breast cancers, all who have received an AI with a CDK4/6 inhibitor in the first line for metastatic disease and have been on that for at least 6 months. And then these patients are followed by serial ctDNA analysis, first every 8 weeks for the first 18 months and then every 12 weeks until disease progression. And if they develop a new ESR1 mutation that wasn't there at baseline, they're then randomized to camizestrant, another oral SERD drug that's new, not yet approved, with continuing the CDK4/6 inhibitor and a placebo for the AI, or continuing the AI as the control group plus the CDK4/6 inhibitor and a placebo for camizestrant until RECIST progression. So this is treating an emergent new drug resistance sequence with these ESR1 mutations that occur while patients are on CDK4/6 inhibitors plus an aromatase inhibitor. So it's a whole new paradigm to intervene early to prevent emergence of drug resistance by attacking these new ESR1 mutations as soon as they're detectable rather than waiting for RECIST progression. The groups were well balanced for age, menopausal status, ECOG, visceral mets, median time to ESR1 mutation, which is about 22 months in both arms. Median prior CDK4/6 inhibition was 23 months. And then the types of ESR1 mutations in terms of the specific mutations were pretty well balanced between the two arms as well. The top-line data for the primary endpoint of progression-free survival is shown on the upper left-hand side of the slide. The drug was fairly well tolerated, although it does have some unusual effects as an oral SERD, in particular photopsia and bradycardia. Photopsia are flashes of light that don't interfere necessarily with daily activities, but they happen. They're reversible. Sometimes they happen 2 or 3 times a week. They're intermittent, and they're completely reversible upon drug cessation. And then bradycardia was mild. There were no cases of syncope or need for pacemakers, for example. The efficacy signal was very robust based on the forest plot analysis in the upper right-hand side of the slide, again, showing point estimate hazard ratios largely to the left of 1 and overlapping 95% confidence limits, including the stratification variables. Moreover, on the lower right-hand side of the slide, you can see quality of life metrics that favored randomization to the early intervention with camizestrant arm. So that's very reassuring from a clinical perspective as well, to improve quality of life, because none of these patients are going to be cured of their advanced breast cancer. So the whole mission here is palliative treatment and supportive measures rather than curative intent. So a very robust efficacy signal in the upper left, hazard ratio 0.44, 3 zeros after the decimal on the p-value, a brand new treatment approach, and it won plenary presentation at ASCO and simultaneous publication in the New England Journal of Medicine. So in summary, for this section on ER-positive disease, there are numerous new drug classes that are in play now in the clinic, already in clinical trials. I won't go through all of these, but just to show you how busy this space is, there are numerous oral SERDs that are still in development. It's probably likely that 3, 4, or 5 of them will ultimately win approval. Same goes with the PROTAC. There's at least one that looks like it's probably going to be approved. And then there are new classes, CERANs and CERCAs. Those are also in the clinic already and have novel mechanisms of action, hopefully non-cross-resistant with some of the other drugs. Next, let's talk about HER2. This is from Dennis Lehman's original science paper where he did southern blot analysis using a HER2 cDNA probe that he got from Axel Ulrich, who cloned HER2 at Genentech in the mid-1980s. And so Dennis Lehman was the first to discover HER2 gene amplification in breast cancer and its association with increased messenger RNA by northern blot analysis and increased protein, P185 HER2 receptor protein by western blot analysis and immunohistochemistry. This overexpression and amplification was associated with poor clinical prognosis, as you can see in the Kaplan-Meier plots for disease-free and overall survival in the center of the slide. Moreover, this was associated with aggressive tumor biology, as indicated by some other adverse factors that track with HER2 gene amplification, including increased pathologic stage, higher risk of positive axillary nodes, quantitative decrease in steroid hormone receptor expression, increase in the S-phase fraction, DNA ploidy, and high nuclear grade. All of those are significantly associated with HER2 gene amplification. At ESMO, we had the first presentation at the Presidential Plenary Symposium of Destiny Breast 11, a randomized global multicenter open-label phase 3 trial looking at neoadjuvant trastuzumab deruxtecan for 4 cycles, followed by a standard neoadjuvant regimen of taxane with the dual anti-HER2 antibodies trastuzumab and pertuzumab, compared to a standard control arm of dose-dense AC followed by THP, and then a third experimental arm of T-DXd alone for 8 cycles. That arm was dropped due to futility because it was not possible for that to achieve the same pathologic complete response rate as the other experimental arms. So that arm was actually dropped, and I will not show any more data from that particular subset. The primary endpoint here is pathologic complete response rate by blinded independent committee review. The groups were well balanced for key clinical pathologic variables, including age, world region, ECOG status, HER2 expression level. 70+% were hormone receptor positive. T stage were well balanced, about 40 to 45% were T3 and T4. And lymph node positive patients were 88% in this population. So pretty high risk group, to be sure. Here are the top line data for the primary endpoint on the left-hand side of the slide. The PCR rate was significantly increased from 56.3 to 67.3%, a delta of 11.2%. This is highly statistically significant with a p-value of 0.003, so the study met its primary endpoint with statistical confidence. If you look at the forest plot on the right-hand side of the slide, you can see that the improvement in PCR for T-DXd followed by THP was observed across most pre-specified subgroups. The conclusion was that neoadjuvant T-DXd followed by THP demonstrated a significant improvement in PCR versus the standard chemo and dual antibody control arm, and the improvement was observed both in the hormone receptor positive and the hormone receptor negative groups. Post-op, 81.3% of the patients receiving T-DXd had no or minimal residual invasive cancer. That's RCB scores of 0 or 1. So over 80% were RCB 0 or 1 compared to just 69% in the control arm. That's a new record for RCB for a new HER2 targeted agent. Really remarkable, astonishing results even. So T-DXd, THP showed the highest reported PCR rate in the history of HER2 positive early breast cancer. This happened in both hormone receptor positive disease as well as high-risk populations. As I mentioned, many of these were lymph node positive patients. T-DXd was significantly superior in the PCR endpoint. There was an early positive trend in event-free survival, which I can't show you in the interest of time, and the safety profile was also favorable. This result supports T-DXd as a more effective and potentially less toxic regimen compared to anthracyclines and dual antibodies in the neoadjuvant settings. Overall, there were lower rates of grade 3 adverse events, serious adverse events, AEs leading to dose interruption, lower rates of hematologic toxicity, lower rates of left ventricular dysfunction, and ILD rates were low. There was just 1 grade 5 ILD in each arm, including one in the control arm. So that was not, mathematically a problematic issue, although it behooves us to pay very much attention for screening for ILD in these curative intent patient populations. Next, I'll tell you about what to do for patients who do not achieve a pathologic complete response, I should say, with HER2-positive early breast cancer. Currently, we treat those patients with 14 cycles of postoperative TDM1. DESTINY-Breast05, again presented at the Presidential Symposium at ESMO, was randomized TDXD versus TDM1 for 14 cycles in the postoperative phase. And you can see the top-line data for IDFS, the primary endpoint, on the upper left Kaplan-Meier plot. This is a positive study, met its primary endpoint. Hazard ratio was low, 0.47, highly statistically significant. The forest plot on the right-hand side of the slide is a biostatistician's dream, with all of the point estimate hazard ratios falling within the 95% confidence limit of the all-patient population. So the safety, unfortunately, had 2 patients with grade 5 ILD in the TDXD arm and none in the TDM1 arm. So again, we have to be mindful of that particular safety signal in these curative intent patient populations. And these patients underwent a very rigorous screening strategy on study to try to mitigate against ILD toxicity. So adjuvant TDXD demonstrated superior efficacy with manageable safety in patients with high-risk HER2-positive early breast cancer with residual invasive disease after neoadjuvant chemo, representing a potential new standard of care in the post-neoadjuvant setting. This is a list of ongoing trials in this space of neoadjuvant and adjuvant studies with ADCs. I'm not going to leave this slide up long enough for you to read it in the interest of time, but I'll make the slides available to anybody who wants them. Please contact either myself or the meeting organizers if you'd like to see this list yourself and spend more time with it. Next, let's talk about first-line metastatic HER2-positive disease. DESTINY-Breast09 was, for the first time, a comparison of TDXD, in this case with pertuzumab, compared to the Cleopatra regimen, which has been the standard of care since 2012. That is taxane plus the dual antibodies, trastuzumab plus pertuzumab. There's also a TDXD plus placebo arm in this 3-arm study of more than 1,100 patients, but that arm did not have enough events yet for an analysis at the time of this interim analysis, so I'm only going to show you the TDXD plus pertuzumab versus THP arms. This study met its primary endpoint with statistical confidence with a hazard ratio of 0.56, as shown by the Kaplan-Meier on the upper right-hand side of the slide. 4 zeros after the decimal in the p-value. The objective response rate here confirmed 85.1%. That's the highest ever reported for HER2-positive metastatic breast cancer. The PFS benefit of TDXD versus THP was consistently observed across pre-specified subgroups, including the stratification factors. There were true grade 5 ILDs, however, once again, in the TDXD plus P arm, and none in the control. And this is, again, despite screening for that safety signal. Next, I'll show you a strategy of starting out with a Cleopatra-like regimen, finishing the chemo and the dual antibodies, and then, if you're also hormone receptor positive, using a maintenance strategy of CDK4/6 inhibition along with endocrine therapy and continuation of the dual antibodies, trastuzumab and pertuzumab. This is the PATINA trial, randomized phase 3 study after a chemo dual antibody induction. The control arm is the standard of care, which is the dual antibodies with endocrine therapy alone without CDK4/6 inhibition. The study met its primary endpoint. Extraordinary results. The median PFS in the experimental arm, 44.3 months. That's a new record in the history of HER2-positive metastatic disease. Even the control arm outperformed the historical Cleopatra pivotal trial with a median PFS of 29.1 months. During the maintenance phase, there were additional responses that happened on this regimen as well. So confirmed response rates went up during maintenance, and so did the clinical benefit rate, as shown on the bottom right-hand side of the slide. I didn't expect to see that during a maintenance phase, that there would be additional responses beyond that induced by induction chemo and dual antibodies. So that was actually quite gratifying to see. There are a number of other induction maintenance ongoing phase 3 clinical trials, as shown in the slide. Moreover, TDXD plus pertuzumab is now poised to move up to the Cleopatra first-line setting once it gains regulatory and or guideline recognition. And so stay tuned for more of these studies with these induction regimens followed by maintenance. The Demeter trial in the lower left is induction with TDXD followed by maintenance therapy thereafter. So you could, in the future, envision a TDXD induction followed by a PATINA-like maintenance in the ER-positive subset, for example. That trial hasn't been proposed yet, but it could be the wave of the future. Next, let's talk about PI3 kinase mutations briefly. There's a new PI3 kinase inhibitor, inavolisib, that can be combined with palbociclib and fulvestrant in the first line for high-risk steroid receptor positive patients being treated with CDK4/6 inhibition and fulvestrant. This study was positive, and let me see if I can find the result here for you. Sorry, I got off track here a little bit. There we go. Yeah, this study was positive, and inavolisib is a PI3 kinase alpha inhibitor with a high degree of selectivity of alpha compared to beta, gamma, or delta isoforms. And so the top-line data are shown on this slide for both PFS on the left and OS on the right. The OS signal was statistically significant. This is the first time OS has been significantly improved with a PI3 kinase pathway targeting drug. The drug does cause some hyperglycemia, stomatitis, dry eye, etc., but it's felt to be manageable in most cases. And the median time to first subsequent chemotherapy in this arm was almost 2 years, 23 months, another extraordinary achievement for a first-line treatment regimen in ER-positive metastatic disease. Another way to attack this pathway is using a pan-AKT inhibitor, in this case, capivasertib, and this is a positive randomized phase 3 trial of capivasertib with fulvestrant in previously treated hormone receptor-positive metastatic patients, and this one has won FDA approval, so this is already available to you now in your practice if you so choose. There are many other PI3 kinase AKT pathway inhibitors in clinical development. Gedatolisib, for example, is a PI3 kinase mTOR dual inhibitor that appears particularly promising, although it's given IV. There are mutant-specific PI3 kinase inhibitors, and there are AKT inhibitors that are also in development that are mutant-specific. And so these are forecast to enter the therapeutic armamentarium in the not-too-distant future. Next, let's talk about DESTINY-Breast06 briefly. This is a comparison of T-DXd versus treatment of physician's choice for those patients who have finished all their endocrine therapy and they become endocrine refractory with metastatic disease, and they would ordinarily go on to take chemotherapy. But this trial compared T-DXd, the antibody-drug conjugate, head-to-head against chemo du jour of physician's choice. And this is, again, a positive study favoring T-DXd, hazard ratio 0.62 for the PFS endpoint, highly statistically significant. And so this establishes T-DXd as a new and effective treatment for patients who are endocrine refractory, who have HER2 low status or even ultra low HER2 following at least one prior endocrine therapy, usually more than that actually. The definitions of HER2 low and ultra low are published in the paper, and so I won't belabor that point now. You'll have to ask your pathologist if you want that determination made in your clinic. Dato-DXd is a TROP2 antibody-drug conjugate with a DXd payload. This study, TROPION-Breast01, is for patients who have had 2 or 3 lines of prior endocrine therapy, and again, a positive study, randomized phase 3 trial with a treatment of physician's choice control arm. The FDA approved this in January of this year, so this is now newly available in the hormone receptor positive population as well. So Dr. Laura Huppert at UCSF has put together this beautiful roadmap for treatment of hormone receptor positive metastatic disease. And if you're interested, I would staple this to the wall of your clinic so you can remember all these trials and all these details. It is hard to keep up. It seems like about every 6 to 8 weeks there's another new FDA approval or breakthrough presentation at a big international conference in the field. Lastly, I'll spend the last 5 minutes on triple-negative breast cancer. As you know, it's less common, 10 to 15% of all breast cancers, particularly found in premenopausal women and in black patients as well. 5-year mortality rate is unacceptably bad at 30%. There are new drugs now that have been tested in the first line for PD-L1 negative patients or patients who are not candidates for checkpoint inhibition for any other comorbidity reason. And there are 2 of these TROP2 antibody-drug conjugates now with positive phase 3 trials. The ASCENT-03 trial used sacituzumab govitecan, a TROP2 antibody-drug conjugate with an SN38 payload that blocks TOP1. Positive randomized phase 3 trial hazard ratio 0.62 highly statistically significant. TROPION-Breast02 is a similar strategy with the datopotamab deruxtecan, again, a TROP2 antibody with a DXd topo-1 inhibitor payload, hazard ratio 0.57, p-value less than 0.0001. The patient populations in these two trials are sufficiently different that the outcomes cannot be compared head-to-head. They're shown only for illustrative purposes on this slide for the purpose of expediency to put them both side by side. This is not meant to be a direct comparison. The patient populations are far too disparate in order to do that, so I would caution you not to use that in clinical decision making. ASCENT-04 was a sacituzumab plus Pembro versus chemo plus Pembro campaign in first-line PD-L1 positive metastatic triple-negative disease, and it met its primary endpoint of PFS, big study, over 440 patients, hazard ratio 0.65, p-value 0.001. So sacituzumab plus Pembro demonstrated statistically significant and clinically meaningful improvement in PFS versus chemo Pembro by a blinded independent committee analysis with a 35% reduction in risk of progression or mortality. So it's hoped that the regulators will take action on this data set in the not too distant future, and this will also become available in practice soon, we predict. Last slide is another approach of this ADC plus immune checkpoint inhibitor strategy. In this case, Dato-DXd with durvalumab. We were talking about waterfalls a minute ago. Look at the one on the left. That's like Niagara Falls of breast cancer research there. Huge response rates with this particular combination. Non-randomized phase 2 data, small study, but very, very impressive results. And look at the durability on the spaghetti plot on the right-hand side of the slide. These patients with these immune-mediated responses tend to have durable responses, at least in this study. So this regimen is now in a phase 3 trial that is just starting. So that's going to be, hopefully, very impactful based on this phase 2 data. In conclusion, these are the 3 ADCs that I touched on today, and the label indications in the fine print from the package inserts after recent FDA approvals for all 3 with new indications. So fast-moving field, thank you for your attention. I hope you'll get something out of it, and if you like, I'll be happy to share the data with you and hopefully integrate some of these new approaches into your clinical practice soon for the betterment of our patients. Thank you. Less than 4 hours. Not much.
I'm a community oncologist, so I have questions.
Good.
We were actually part of the SERENA-6 trial.
Maybe use this one. Okay.
Can you hear me?
That's better.
Yeah, there we go. So thank you for the great summary. I'm a community oncologist, so I have a couple of questions for you. We were part of the SERENA-6 trial, and we were fortunate to enroll a number of patients. Based on the results you just showed, how do you advise community oncologists to incorporate that into their practice, and is this ready for prime time? And if you don't mind maybe touching on liquid biopsy in general and how you, incorporate that into your practice.
Great question. You know, this always comes up the day after these big meetings, is when are we ready to pull the trigger and start doing this in practice? And there are early adopters in the community who do it right away, and then there are other people that are more circumspect and wait for longer follow-up, more data, regulatory approval, insurance authorization, et cetera. So right now, this is not yet approved by the FDA, nor is it recognized by the NCCN. So I assume you would probably struggle to get compensation for this strategy at the moment. So I don't think it's ready for prime time in the clinic yet. I'm very anxious to see what the FDA has to say about this approach. Just because it was a plenary session and published in the New England Journal doesn't guarantee regulatory approval. And I've seen back-of-the-napkin calculations, just for instance, where if you take the SERENA-6 control arm, wait for them to have RECIST progression, and then put them on the experimental arm of the Emerald trial with elacestrant, you wind up at about the same number of months as PFS2 in that experimental arm where you're doing all this testing. Now, that's not a fair way to look at this because you can't do these cross-trial comparisons, just add up PFSs from one trial and another trial. They're completely different patient populations, et cetera. But the fact that you can still get these kind of similar results by thought experiments is of concern, and this was brought out by the discussant in the plenary session indeed. So I'm not an early adopter for the ctDNA approach yet. I'm very anxious to see what the regulators have to say about it and see what NCCN has to say about it. So far, even NCCN has been silent about this. So I'm going to wait and see. But there's a high enthusiasm. Many patients want it done right off the bat. So there's a lot of pressure to do this from patients, and that's tricky in clinic to know how to handle that.
Thanks, Mark. It was amazing review in such a short time, but I didn't expect any less. So before you came, I showed my anti-ctDNA bias, so I won't bore the audience again with that. Just have a question about Destiny Breast 11. So as much as we are excited about 2 out of 3 path CRs, the 1 out of 3 that don't achieve it, I know you're going to say we're in a data-free zone, but what do you do for those patients after that approach if they have residual disease?
Yeah, that's a really interesting question. And I think, in my mind, it depends on the depth of their response. Even if they don't achieve a path CR, they might get an RCB1, for example, which means they probably had a robust response to just 4 cycles of TDXD and then THP for 4 cycles. And that kind of gives me enthusiasm to give more TDXD in the post-neoadjuvant setting based on Destiny Breast 05, because they probably will continue to respond if they had a robust response to begin with. If, on the other hand, their response is anemic and their RCB3 or what have you, I would have no enthusiasm to give them more TDXD. And probably little enthusiasm to give them TDM1 either. I bet that's not going to help a lot. But what else are you going to do? I'd probably maybe give them some anthracyclines at that point for a few cycles, to be honest with you, right?
Yep.
If they're anthracycline naive patients. In the US, we don't use ACTH as the control arm. We use THP or TCHP almost exclusively in this country. But anyway, so the answer is I think it depends on how robust or how lack of robust efficacy you got in the degree of the non-PCR, basically.
Yeah. So, and if they're ER positive, would you discuss neratinib with that type of a patient?
Sure. If they're high risk, absolutely. It's still on the table. I talk about extended adjuvant HER2 targeted therapy with neratinib in locally advanced patients, largely. I usually restricted to that population, maybe some high-risk stage 2s, but because of the toxicity of that approach. And patients are they struggle to start another new drug, late in their adjuvant treatment course. Psychologically, that's difficult. And then you have to use the control trial ramp up of dose of neratinib to try to mitigate against the diarrhea from that drug, which can be incapacitating if not managed well. But yeah, it's on the table, particularly in the hormone receptor positive patients that had an OS signal of sorts in the Extenet trial. In a subset of a subset of a subset of a subset analysis. And I'm not joking about that either. That's
Thank
true.
you.
Yeah, it's data mining, but they did find a signal for OS, which is required, by the way, for European regulatory authorities, so that they had to do it. Yeah.
Would you consider a hybrid in the clinic, a hybrid approach with the TDXD instead of 14 cycles of adjuvant to give a predefined number of cycles, switch to a different maintenance, i.e. patina-like approach, whether it's the adjuvant or even in the metastatic first-line endocrine therapy in an attempt to improve tolerance and reduce toxicity?
So in the neoadjuvant setting, I view Destiny Breast 11 as a de-escalation opportunity because you're increasing the PCR rate, and that means those patients don't need either ADC for 14 cycles. 14 cycles of TDM1 is difficult. My batting average is about 11 cycles. I tell patients up front they're probably not going to finish all 14, even with TDM1. They get thrombocytopenia, elevated LFTs, neuropathy, et cetera. TDXD, same thing. Only 72% of patients got all 14 cycles of TDXD. So a de-escalation arm in the neoadjuvant setting is afforded by DB11, to be sure. Now, the post-induction phase in first-line metastatic disease that you mentioned is a good one. And that Demether trial is a perfect example of that, where you start out with a TDXD induction, And in that trial, it's only 6 cycles. I would rather see it used for as long as it's effective and tolerated, because we don't stop at 6 cycles routinely in practice. We give it
To
for as-
maximal response, generally, as long as it
if
is
they're
tolerated.
responding and they're tolerating it satisfactorily, you can give 7, 8, 9 cycles if you wish, in my opinion. Certainly off study, you can do that. And then if they're steroid receptor positive, they could do a patina-like follow-on regimen. I was at a meeting in San Diego about 4 to 6 weeks ago, and there was an audience response case polling question to the audience, and it was this issue of an induction TDXD followed by a patina maintenance. 85% of the audience voted for that. I said, how can you vote for that in the absence of any data whatsoever? They said, we don't need any data. It's the obvious thing to do. And it's probably going to be in the long run, that's probably where we're going to wind up. And I have to agree with that. I think that is probably an achievable goal. Yeah.
So with so many options available, do you have a preference on sequencing the available treatment options, mainly in a patient
boy.
who has ESR1 PIKF mutation and HER2 low?
A coin toss, I think, is probably appropriate. I'm not just kidding. It's very difficult to know. There are no data to guide us. There's some retrospective chart review data with very small numbers of sequencing of antibody-drug conjugates. They were presented at San Antonio 2 years ago. There was a French study, a Boston study, and a UCSF study. They all showed the same thing, even though there were small numbers each. They showed that the first ADC has the longest PFS and the second one has the shortest, 75% of the time, no matter which one you start with. The first one you use will always be the better one. Whether you start with sacituzumab or start with TDXD, the first one is always better, 75% of the time. So now with endocrine manipulations and PI3 kinase mutants, if they have dual mutations, in the elacestrant pivotal trial, there was a subset analysis looking at the PIK3CA mutant subset of ESR1 mutants. So they're dual mutants. And there was still an efficacy signal in patients randomized to elacestrant. It's exploratory, it's subset analysis, it's data dredging to be sure, but it looks like there's a signal there. Moreover, conversely, in this new AKT inhibitor called, what's the name of that one? There's one that isn't approved yet. It's a cousin of capivasertib. Ipatasertib is the name. And it was withdrawn from development because it failed in breast cancer because it was combined with chemo in a bunch of studies, and it was too toxic. So it's on the shelf right now. But in a randomized phase 2 study of that drug, in ESR1 PIK3CA co-mutants, treatment with that agent also led to superior PFS compared to the control arm in the co-mutated patients treated with an AKT inhibitor. So that suggests to me you could probably use either one first, because both approaches have been shown, in subset analysis granted, to be effective when there are mutants in the other target at the same time. So I think you could probably do either one. And if you're going to do either one, the other metric I use in my clinic to make that decision is safety signals. Because these are all palliative treatment regimens. So I try to maximize the therapeutic index, which is efficacy divided by toxicity. So in that case, the oral SERDs win, in my opinion, because they're better tolerated than the PI3 kinase or AKT pathway drugs, for sure. They're just better tolerated. And so I'd probably, in an endocrine therapy case, I would use a SERD before a PI3 kinase inhibitor, personally.
And so just a follow-up on this. So in a patient with high tumor burden, would the early drop in the Kaplan-Meier curve for SERDs make an impact on your decision?
Probably not. The elacestrant phase 3 trial was a very visceral, predominant, and high-risk metastatic population, heavily pretreated. They all had prior CDK4/6 inhibitors, for example. And in subset analysis, even the visceral patients had a favorable response to elacestrant compared to endocrine therapy of physician choice. So, visceral disease doesn't rule out the possibility of effective endocrine manipulation. And sometimes these endocrine manipulations can last for many months. So it's probably worth a try, but do the early staging to weed out the rapid progressors to be sure. And we need to study those patients to be able to identify them prospectively so we don't put them on SERDs at all. in the future. But right now, we don't have any insight as to the biology of those resistant cases. They have kind of the usual suspects in terms of the types of ESR1 mutations they have. So nothing stands out that we've seen so far to be able to predict those patients. So we need to study that more intently to figure those cases out.
I had one question about, you showed some preliminary data, the combination of antibody drug conjugates with pembrolizumab. It is extremely difficult for us to recognize, prevent, treat interstitial lung disease. Where do you think this is going for our patients?
It is a real challenge, and all I can say is to follow all of the high-res thoracic CT intervals that were used in the protocol, even off-study. I think it behooves us to use the same rigor to try to understand lung inflammatory conditions in those patients, and it may be difficult to sort the two out, whether it's an autoimmune phenomenon for the immune checkpoint inhibitor or a direct toxic effect from an ADC. It takes a lot of kind of synergy between various experts, pulmonologists, infectious disease experts, medical oncologists, to try to sort out some of these lung conditions. I'll tell you, in some studies now, it's been found that the steroid-treated suspected ILD patients sometimes get pneumocystis from steroid treatment. That's been seen now in some of these trials. And so if you're going to treat for more than a couple weeks or certainly a month, those patients with high-dose steroids, those patients need to be on pneumocystis prophylaxis. And we never really think of that, but you have to. You have to. Someone was talking earlier in the lung session about being a good general internist still. We as oncologists still have to remember the basics, don't we?
Triple-negative breast cancer not eligible for immune therapy. Dato, DHD, or SG, first line?
I don't know. I don't know. I don't know. There's no head-to-head comparison. So I'll tell you what, the Dato trial had a higher response rate, if that impresses you, but it's a different patient population. But they both met their primary endpoint with statistical confidence.
With
and
the
respectable
OS, with the
hazard.
Dato sway you in one
Well,
direction?
that's a great question. The Dato trial had a dual primary endpoint of PFS and OS, and the sacituzumab trial did not. And moreover, the sacituzumab trial allowed crossover, which contaminates your OS statistical power. And a high fraction in that trial did indeed cross over already. Mm-hmm. So we may never see an OS signal in the sacituzumab trial. And I don't think that should be held against the drug. I mean, the sponsor was doing the right thing for the patients who were on the study, in my opinion.
It's good that they allowed crossover.
And I like crossovers for my patients on those studies. And so I would hate to see a demerit be issued for that when it's the right thing for patients.
Shouldn't be punished for doing the right thing.
Exactly, you should not be. And so I'm going to vote against the dual primary endpoints of OS and PFS for the Dato trial because while it's interesting, we may have seen the same thing in the sacituzumab trial had they done similar trial designs.
Maybe one last question. I have 3 minutes. Sure. I wanted to ask your experience about adjuvant CDK4/6 inhibitors. A lot of these women, especially younger women, had pre-treatment with chemotherapy. We have a lot of experience in women in the metastatic setting who, with bone-only disease, who tolerate CDK4/6 inhibitors really well. Mm-hmm. And I think it's a little bit disappointing to see that we have such a non-compliance rate or adherence rate with CDK4/6 inhibitors in the adjuvant setting.
Sure.
And I wanted to get your take on that.
Well, this is not breaking news by any stretch. The adherence to aromatase inhibitors in the community is terrible, on or off study. We're talking double-digit rates of discontinuation before 5 years just with ordinary AIs. So it doesn't surprise me at all that we would see the same thing with CDK4/6 inhibitors that arguably have even more toxicities than endocrine therapy alone. So it's a risk. I mean, all you can do is try these drugs. You can start patients on them. I tell patients that every day they're empowered to make the decision whether to continue or not. And that's absolutely true. Some will choose not to, and in some of those cases, that may be a wise decision. I have no regrets, but as long as, in my case, if they'll just do me the favor of doing the college try and see if it works, a lot of patients will be able to continue it for the full course, and the ones that can't, at least you tried. That's the best we can do, I think. I do like the lower dose of ribo in that regard. It is particularly well tolerated compared to abemaciclib, in my opinion. Yeah.
Thank you very much.
Thank you.